My name is Shah. I'm a radiation oncologist. I serve as the director of breast radiation oncology at the Cleveland Clinic. With the publication of multiple randomized trials, growing data supports the use of partial breast irradiation following breast-conserving surgery in patients with early-stage breast cancer. It's important to recognize that the initial trials evaluating breast-conserving therapy utilized standard whole breast irradiation given over 5 to 7 weeks. Also, studies have found that the omission of this radiation led to increased rates of breast cancer mortality. More recently, hypofractionated whole breast irradiation has emerged, but this still requires 3 to 4 weeks of radiation. Partial breast irradiation was initially evaluated almost 20 years ago and has subsequently been evaluated in almost 10 randomized trials in the United States and beyond. Importantly, the original randomized trial evaluating partial breast irradiation was recently published with 20-year outcomes, demonstrating no difference in the rates of recurrence when using interstitial brachytherapy as the primary partial breast irradiation technique. NSABP B-39, also known as RTOG 0413, evaluated partial breast irradiation versus whole breast radiation. 10-year outcomes presented in the Lancet demonstrated that the trial did not meet its equivalence endpoint, though the absolute difference in recurrence was quite low between the two treatment arms. Similarly, rates of side effects were low, though it's important to recognize that the partial breast group had primarily 3D conformal partial breast irradiation, which has been associated with increased side effects in other studies. In comparison, the Florence randomized trial provided 10-year outcomes using a regimen that incorporated intensity modulated radiation therapy as compared to whole breast radiation. At 10 years, this technique was associated with comparable rates of local recurrence with reduced side effects in the short and long term. The RAPID trial used the same type of technique that NSABP B-39 used, which was 3D conformal partial breast given twice daily for a week, and compared this to whole breast radiation. At 8 years, no difference in recurrence rates were seen, though the partial breast technique did seem to be associated with a greater rate of side effects. In terms of partial breast radiation eligibility criteria, clinicians can use the inclusion criteria from the trials, or they can use cooperative group statements on inclusion from the American Society for Radiation Oncology, the American Society of Breast Surgeons, JEC-ESTRO, or the American Brachytherapy Society. In my own practice, I tend to evaluate patients for partial breast based on several features. The first feature is age, and I primarily limit partial breast irradiation to women 50 years or older. With respect to tumor size and type, I typically allow for women with DCIS, as well as tumors that are invasive of 3 centimeters or less. I prefer to have patients that are estrogen positive without lymphovascular space invasion and that are node negative. It's important to note that some of these patients may not undergo sentinel lymph node biopsy, and that's okay if they meet criteria for that, and I'll still offer them partial breast irradiation. Finally, at the time of surgery, we like to ensure that patients have negative margins. For patients with pure invasive disease or invasive disease with DCIS, this means a margin greater than 0 or no tumor on ink. In contrast, for patients with DCIS, as the only histology present in the sample, I recommend a margin of at least 2 millimeters to be an appropriate candidate for partial breast irradiation. In terms of techniques, I offer all types of techniques, including brachytherapy, which includes interstitial and applicator brachytherapy, external beam, which I primarily deliver with intensity modulated radiation therapy at this time. The NSABP B-39 or RTOG 0413 trial evaluated partial breast irradiation therapy as compared to whole breast irradiation.